Here's a question, yes.
As a dentist, my knowledge base. I said, as a dentist, my knowledge base in all these things is quite low. I came here because of my wife, but I just wanted to know. I'm joking, but in any case, I just want to know if there's a course that I can learn a little bit more about appliances, and then of course I could work with her on. So I don't know if anybody could shed light on that.
I'll be covering some of that in that structure fund.
Actually, I have a brochure in the back.
Stand up.
Come on.
Yeah, so I actually recommend taking Steve Olmos's program. It's like 3 very long weekends, and I've actually put the brochures for it in the back. Teaches motor reflex testing, understanding jaw position, research, airway, sleep apnea, the lot. If you can really comprehend what he's saying, you'll be good to go after the last session. Yeah. Steve Olmos. Steve Olmos.
Is that a question or stretching? Watch, getting your hair. Your hair look good.
Yeah, he teaches out of Memphis.
Any other questions?
Dental school.
Thank you, and thank this august group of experts. I really appreciate it. I'm a dentist also, and I'm like the gentleman up there, except back in the late 70s, I started to change that and began to learn some things. My first question is, do you actually check to see if the temporal bones are moving gently 2 to 3 times a minute when you're looking at your dental appliances? Yeah.
I'll have you answer as well. Like, I don't know what you do. So if I'm doing, okay, if I'm doing ALF therapy, yeah, I am checking. I can't feel to the extent that Richard can feel and Charles can feel and the osteopaths in this room can feel. But when I'm not doing functional orthodontics, like with ALF and myofunctional therapy, I am not feeling for it. I'm doing motor reflex testing, so I understand the structure of origin first. And I'm looking at everything else that goes. I'll talk about it tomorrow. Yeah. Yeah.
Did you respond?
I thought you wanted to comment.
No, I wanted to hear whoever had it.
No.
I mean, ultimately, from a cranial perspective, they're not feeling the cranial rhythm. What they're feeling for is more of mobility and sutural compression, so that if they're getting a really sutural compression, which is really the only way that if you don't feel a rhythm that you can do that. So I mean, I'm not trying to speak for you, but you don't really feel the cranial rhythm as much as, okay, it's a little more mobile, just in kind of range of motion kind of sense, because that what you're talking is really having the feel of a cranial practitioner actually feeling that rhythm. And I mean, the majority of dentists are never going to, because they're not going to slow down and do enough training to get there, and there's not really enough training available for them. So the whole idea of this is this interdisciplinary. It's like, okay, they can do the basic. They can do the basic, just feel a looseness. So that it's really, that's why we're here. I mean, it's like, okay, what do you feel? Because they don't really feel it. I mean, they feel something, but they don't really feel that cranial rhythm per se. So, and we don't expect them to. It's actually good enough to get just that basic feel with the compression or sutural tension pattern.
Yeah, I was going to say, we look for patterns of cranial distortion. We look for the neurological indicators, and we can see that that's happening. When you're doing any orthodontic therapy, and this is what I found, even if you're pushing it towards correction, you're going to distort the cranium. So we monitor that as we go along. And that's why it's good for me to diagnose a malocclusion, but I'm going to let him fix it, and I'm not going there. And he can see maybe there's something going on cranially, but he's not really going to go there. We do our jobs and work together. We're going to get the result we want. Does that make sense?
One last comment. I do put my hands on virtually everybody's head when I adjust their alpha appliance or their orthotics. Okay. What I am feeling, I have no idea. Okay. All I know is that I get feedback, and somehow it says adjust the left side a little bit more. Okay, until I feel some sense of balance or harmony. I don't know what that is. Okay, all I know is, I've worked with Dr. Nordstrom for almost 15 years now, and one thing I'll tell you, when you have someone that has the kind of I don't know, aura or whatever it is that he has. Okay, I feel things going on in my office when he's there that just doesn't happen when he's not. And likewise, when Richard's there and when the osteopaths are there, I sometimes I know what I need to do before I even walk in the room. And there's something about energy and all that kind of stuff. So, needless to say, there's a whole lot of stuff we don't know a whole lot about. And so, but somehow I get some kind of messages, and it seems to be working.
When it's all said and done with all the research in the world, it's all about clinical outcomes, and if the patient's feeling better, less pain, more function, that's where the rubber meets the road. Any other questions? Yes.
Thank you. There are dental courses from like the Cranial Academy, and I think that the osteopaths were teaching dentists because we messed up more people than you could shake a stick at. I mean, the forces for extracting a molar, in the old time we had those cups that you'd lay against, and the patient would try to get away from it, and it would compress the temporal bones. And I'm one of those people who can feel like probably comparable to Derek or whatever. I've been doing this for a long time. And there are classes, taught on exactly how to feel those strain patterns, but it's subtle. I mean, Tom, the work you did today blew my mind. Really, it was at such a high level, and it wasn't what I was used to from that perspective. The next question is, can you talk about anything about the dural movement relating to the cranial diaphragm, the thoracic diaphragm, and the pelvic diaphragm?
Who are you? Repeat the question again.
Okay. I'm interested in there was Dr. Fryman wrote an article about the core link in the three diaphragms and how the dura, the cranial diaphragm, was linked to and affecting the thoracic diaphragm and the pelvic diaphragm. I find often that if I have a restricted left temporal bone, for instance, that when I palpate the lungs from under the body, the side with the locked temporal is moving in the exact opposite direction as what we would expect, both lungs descending, both on an inhale. And so that's what I'm asking about.
Some of the things that I see when you talk about temporal distortions, start to think of more dural torque side-to-side motions, such as scoliosis. And there was a study that came out in Canada last year that linked abnormal vestibular responses to idiopathic scoliosis. And those of us in the cranial field have known for years that temporal bone distortions, if severe enough, start to cause a scoliosis. And I've seen that when a 12, 13-year-old is in the middle of orthodontic therapy, the cranium's locked up. Even if you're pushing it the right way, and it can happen really fast. My own daughter went in a 2-week period, I didn't treat her, and looked, and she started to develop a scoliosis, and I turned it around. And I think in talking with Dr. Budding over the years, there was some talk about anterior to posterior excessive motions more related to the falx cerebri and how the body reacts to that. But then again, I think you said earlier, it had a really good point, and even in my presentation, when the mandible goes back, the cranium torques, the TMJ compensates, the head goes forward, you're going to compress the diaphragm here right away, just on a pure mechanical level. And so I think there's neurological influences and mechanical ones as well.
I think the big thing Dr. Fryman was talking about was the relationship between the myofascial system and how the dura tends to be a part of that myofascial system, and it attaches from all the way. And so that when you affect one, it affects the other. And that's, Dr. Upledger talks about the transverse planes of fascia, and that as you start affecting the body in the longitudinal or axial level, it has an effect at those transverse planes, just the respiratory diaphragm, pelvic diaphragm, and the particularly the tentorium area. So I think that's kind of what she was talking
And
about.
John Howitt, who's a great craniopath from England, who's not here, did a book on craniofacial dynamics, and he talks about some of that in there too, and I think it's good to
So I think
look
there's
at
the
that.
myofascial influences, the cranial-sacral relationships, and we're going to talk about it either later today or tomorrow. Also, the mechanoreceptors, the visual vestibular plantar reflexes, would create those same patterns. That's what's very interesting regarding cranial, that when you look at the cranium and you just look solely at the dura and the way it attaches, it creates, you would expect cranial motion a certain way. And then if you look at the way the sutures are beveled and connected, you'd expect movement a certain way. And when you look at everything, it all moves the way you would expect it to, and then each way is, whether you look at the sutures or the dura, they all sort of create that same sort of movement. So let's, we're gonna take a break now for 10 minutes and come back. Dr. Gerardo is very kind and is letting me, I'm going to do the exercises, the oral exercises that we're going to do tomorrow, today, and then tomorrow he's going to do the section on
Functional versus standard orthodontics and some of the appliances and the basics, excuse me, so that you get kind of an orientation, a little bit of terminology, but understanding functional versus traditional, so you kind of get an orientation. So that really is going to be a class for mostly for the chiropractors to get kind of, okay, that's what you're talking about, because it's speaking a different language. And I've taught the class before, and it's like, because it's, how do you approach a dentist? How do you even evaluate a dentist if you don't know anything about the appliances? What he says, oh, no, I'm doing that. And you're like, okay, how do I say, no, you're not. I don't like what that's doing, but I don't know how even to talk to the guy. So this is about creating, again, about increasing the ability to create a language that you can actually get across the message of, okay, what you're feeling versus, okay, that appliance is not working right based on what I know because of the basic understanding of mechanics.